Please start.
Yeah, okay. Good evening, ladies and gentlemen. Welcome to Secrets of Neurology, a knowledge feast for all neurologists. This series is probably one of the longest running web series in the field of neurology in India. Today is episode 20, and we usually start by 8 p.m. and conclude by 9:30 to 9:45 p.m. We would like to give a very warm welcome to our course directors of Secrets of Neurology, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir. Sir, thank you so much for giving us an opportunity to be a part of this series, and we wish that you keep us guiding to do such type of educational initiatives. We would also like to give a warm welcome to the faculty of Chengalpat Government Medical College. It's an honor and privilege for me to briefly introduce Dr. Sudhir Shah sir. We all know him extremely well. He is professor and HOD at NHL MMC and SVP IMSR Ahmedabad. Dr. Sudhir Shah sir is also a director of neurosciences at Sterling Hospital, Ahmedabad. Many awards and rewards have been awarded to sir's credit, most recently being awarded the fellowship at Royal College of Physicians. Apart from that, he also has been awarded Padma Shri because of his work to society, science, and patients at large. We welcome you, sir.
Thank you.
Our second course director, Dr. Lakshmi Narasimhan sir, is equally contributive. Many awards and affiliations have been awarded to Dr. Lakshmi Narasimhan sir as well, like Palatucci Advisor Award, Best Paper Award at American Academy of Neurology, Global Elsevier Award, Atlas Award, and so on. Sir, the entire neurology student fraternity is extremely thankful to both of you as course directors. Sir, may I now request both of you to take it forward from here. Thank you so much, sir.
Thank you. Thank you, Dr. Haley, for that candid introduction. And I think everybody now knows about this series, and I would rather not invest more time, but to say that this web series, is really unique and one of its kind. And by so far we have now contribution from 19 different medical colleges with the neurology registrars presenting the cases. Assistant professors gives guidance regarding the localization, etc. And etiology and other aspects are being discussed by either associate professor or the professor. And of course, we have wonderful discussions and deliberations and question answer session. To be, to share with you, we have everything on our YouTube thing, and if a demand, you can ask us or Intas people will provide all the different episodes, and I can assure you this is a wonderful feast for all students of neurology. Why only neurologists? So many consulting, practicing neurologists, and even the teachers also are so much impressed with the content and deliberations that they also have appreciated, and many of them regularly attend. So that is it's a classic kind of series, I can tell you. And I must share the fact that much of the success is due to the hard work by my friend, my colleague, course director, Dr. Lakshmi Singh also. And together we had dreamt of such type of series, and look how successful it is running. And we have always more than 150, 250 people attending this course. So that is one thing. And Dr. Lakshmi has been introduced, but my duty is to now introduce the faculty today. And today, as you know, we have Chengalpat Government Medical College as participating college, and the senior resident who will present the case will be Dr. Rajesh Kumar. It is intractable vomiting with some brainstem syndrome. That is the title of the case that they have given. And I'm sure you will all start guessing what it could be, whether it is a demyelinating lesion or some space occupying lesion or something in the fourth ventricle floor or whatever it is. So I think I leave to your imagination while the case is being unfolded. As you know, Chengalpat is a very important area of India, and much of the work regarding tuberculosis and Mycobacterium leprae, both mycobacteria, has come from this area, Chengalput area, and we must appreciate the scientific research being done in this area. So, Government Medical College is also one of its kind, which Lakshmi has been telling me very good words about the kind of research and kind of scientific discussions they regularly hold in the college. The next one is our senior assistant professor, Dr. Balaji G, who is from the same medical college, and he will be, I think, dissecting the case, trying to localize and maybe sharing some etiological aspects. And I think he belongs to Madras Medical College, and Dr. Lakshmi told me that he was a student of my friend, Dr. Natarajan. So, am I right? Yeah. So that is Dr. Balaji. And the next one, the associate professor, the senior most person here, Dr. Elan Bowen S., who would be the person who would give us final highlights. And I'm sure with his pulse of wisdom, we all would become enlightened and wiser. He is an MBBS MD General Medicine. He has done DMD from Stanley Medical College, Chennai, and he's associated as assistant professor with the same college from 2008 to 10, and then he moved to Thanjavur Medical College, Newari Department, from 2010 to 2021. And here in this college, he has taken charge as associate professor with Chengalpat Government Medical College since 2021. So with this brief introduction, I now request Professor Rangavan to take over. And once again, I want to thank you for accepting this deliberation, presentation, and I must thank INTAS, particularly the Global Cell Division, for these wonderful arrangements and the infrastructure and logistics that they have been providing in all these episodes. So I thank Mr. Chadda, Dr. Haley, and Dr. Manoj and the team. I must thank all the participants who have shown their patronage. Their confidence in us is the only reason why we have been able to continue this long series, and we hope to continue for further several webinars, maybe another 10, 12, 20, whatever. So I must thank all the participants and delegates. Once again, thank you very much. Professor Ila, go on, please. Please
unmute yourself, Dr. Ilangavan.
Thank you very much, sir. Respected course directors, So Professor Shah sir and Professor Lakshmi Narasimhan sir and all the faculties, good evening to all. Thanks for allowing us to present the case. I thank Professor Dr. Lakshmi Narasimhan, my teacher for more than 17 years, guide, giving us the opportunity. Now I request Senior Resident Dr. Rajesh to present the case. Rajesh.
Good evening to all my respected professor. Today I am presenting an interesting case in intractable vomiting and acute brain syndrome. Mrs. Almelu, a 25-year-old female from Kachipuram, studied till 10th class, homemaker, right-handed, presented with following chief complaint of nausea and vomiting for 20 days, swallowing of species since 3 days, difficulty in swallowing since 3 days. History of present illness, the patient was apparently normal before 20 days. Then she developed nausea, vomiting, and hiccups. Several episodes of vomiting per day. Vomiting contain food particles, not bile, not blood, not associated with vertigo or headache or abdominal pain or fever. Hiccups came in clusters lasting more than 2 hours, several times in a day. For above complaints, she consulted a physician and was treated with PPI and antibiotics. Her symptoms were not relieved until 2 weeks of treatment. She got admitted in our medical college medicine department and evaluated and treated with injection PPI, thiamine, and antiepileptics. After 4 days, she was discharged with symptomatic improvement. After discharge, she presented to our OPD with following complaint of 3-day duration, difficulty in swallowing for both solids and liquids with pooling of saliva in oral cavity, difficulty in marshalling food with tongue, slurring of speech, swaying while walking to either side. Above complaint were subacute in onset and progressive. She was able to hold plate, mix food, and take food to mouth without smearing or clumsiness. She was able to do button and unbutton and lift object above her head without difficulties. She is able to lift her neck of the pillows, get up from bed, stand from sitting position, and turn over in bed without any difficulties. She had unsteadiness while walking to either side with no worsening in the darkness. She did not complain of dizziness or spinning sensation. She has no difficulty in negotiating narrowing pathway. She also complained of new onset headache, which was diffuse in nature, intermittent, lasting 1 to 2 hours, throbbing in nature, and associated with horizontally separate double vision, worsening on distant vision. Double vision and headache lasted 1 to 2 hours, then improved. 3 episodes first day of admission. There was no complaint of any visual acuity problems. She noticed that all symptoms worsened during the evening. There is no history of fatigable weakness.
Dr. Balaji?
Yes, sir. Yes, sir. Yes, sir.
Hello?
Yes, sir. I'm hearing you, sir.
Dr.
Yes, sir.
Ilangovan, it's not,
Yes, sir.
it's not audible.
Yes, sir.
His
Yes, sir.
voice
Audible.
is not audible.
It's not audible, sir. Okay. Go near and make it more.
She was able to feel the own clothes and could appreciate hot sensation while holding teacups. No history of numbness, pin and needle sensation. No history of pinprick sensation. No history of pain in the neck at rest or during neck movement. She was able to appreciate odor in both nostrils. She was able to see the objects, identify colors. She was able to move her eyeball in all directions. There were no history of dropping of the eyelids. She was able to see foods and appreciate sense in our face. She was able to close her eye fully with no facial asymmetry. There was no history of hearing loss, tinnitus, or oral fullness. There is no history of nasal regurgitation or nasal speech. She was able to move. She was able to move her neck on either side and was able to shrug her shoulders. There is no history of decrease or excessive sweating or any of the body parts. There is no history of cold intolerance, dry skin, constipation, excessive sweating without weight loss or weight gain. No history of palpitation. There is no history of seizures, trauma. There is no history of fever, cough or diarrhea. There is no history of delusion or hallucination. There is no history of memory loss. Past history. There was no history suggestive of any similar previous episode. Kerala nerve involvement, headache, eye pain, visual symptoms, diplopia, swallowing difficulties, seizures, loss of consciousness, vaccination, trauma, skin rash, joint pain, photosensitivity, orogenital ulcer, dry eyes, dry mouth. The patient is not a non-case of type 2 DM, systemic hypertension, coronary artery disease. There is no history of hyperthyroidism. Personal history: patient was mixed the diet, normal appetite, married, mother of 2 children, younger child 2-year-old, normal sleep pattern, bladder and bowel habits normal. She attained menarche at the age of 14 years. The last menstrual period is 15 January 2022. The menstrual cycle regular. Family history: there is no history of similar complaint in family member. General examination: patient is conscious, oriented, cooperative, moderately built and nourished. There is no pallor, icterus, cyanosis, clubbing, edema, lymphadenopathy. There is no neurocortical marker. There is no thyromegaly. Pulse rate 76 per minute, normal in volume and character. All peripheral pulses are felt. There is no radioradial delay, no radiofemoral delay, no vessel wall thickening noted. BP was 110/70 mm Hg measured in the left upper limb with the patient in supine position and 100/70 mm Hg in the standing position. There is no postural hypertension. Respiratory rate is 19 per minute, regular in nature, type thoracoabdominal. The single breath count at the time of admission is 32. Temperature 98.6 Fahrenheit measured in the axilla. Nerve system examination: patient is right-handed person. The higher mental function normal. The mini mental system examined 30/30. Language normal. As speech, there is lingual dysarthria. Cranial nerve examination. First cranial nerve. Patient able to feel smell in both nostrils. The second nerve examination: optic nerve, visual active in both eyes 6/6. Field of vision in both eyes normal. Color vision: patient able to perceive color in both eyes. Fundus normal. There is no papilloma. Third post 6. There is no ptosis in both eyes. Extraocular movement full in range both eyes. Pupil 3 mm in diameter and reactive to light. Accommodate reflex in both eyes present. No fatigable weakness. Motor examination: both sides normal. Sensory: patient able to perceive sensation in face, both sides normal. Reflex: both corneal conjunctival present. Jaw jerk absent. Seventh cranial motor: patient able to wrinkle, able to close eye tightly in both sides. There is no deviation of the angle of mouth. Sense: patient able to sense anti-tooth or tongue normally. Reflex: both corneal conjunctival present in both sides. Eighth nerve: Raynaud test in both sides positive. Air conduction more than bone conduction. Weber is not applied to any ear. Cranial 9th and 10th, uvula position. Uvula is centrally placed. Palatal pharyngeal movement, both sides decrease. Gag reflex, both sides absent. Cranial 9, shrugging of shoulder and turning of head, both sides normal. Cranial 12th examination, tone normal. There is no deviation of tongue. Fibrillation of wasting, there is no fibrillation of wasting. Power, both sides decrease, but weakness is left more than right. Motor system examination, bulk, this bulk is normal. Tone, both upper limb and lower limb at time of examination is the tone is normal. Power examination at neck, both flexor extensor are good. Trunk muscle normal. Upper limb at the shoulder joint, abduction, adduction, extension, flexion, both right and left by 5/5. At elbow, both flexion and extension, both side 5/5. At wrist, flexion and extension, both side 5/5. In hand grip, both side 100%. Lower limb examination at hip joint, flexion, extension, abduction, adduction, both side 5/5. And at the knee joint, flexion, extension, both side 5/5. And ankle, dorsiflexion and plantar flexion, both side 5/5. Reflex, coordinate, all are present. Plantar, both sides are fracture. Deep tendon reflex, bicep, tricep, supinator,
message ஒரு slide வேணும்.
both side 2/5.
ஒரு slide இப்ப already report doctor has detected stenosis of the
Sensory examination, spine thermometer examination, pen temperature in both sides intact, fine touch in intact, posting vibration, joint pressure both sides intact. Romberg sign is negative. Cortical sensation, tactile localization, 2-point discrimination, and strogonosis, the diaphragm intact. Cerebellum, the non-stigmas, lingual dysarthria present. Finger nose test, finger nose test, normal. There no intentional tremor. Patient able to perform rapid alternate movement. Heel senior test normal. Patient able to perform tandem gait test. Gait, stance normal. Gait normal. Patient had no turning difficulty, no posterior imbalance during turning. Autonomic nervous system examination. Patient had no resting tachycardia, no increase or decrease sweating. Patient had no sign of manual irritation, no neck stiffness, no curling sign, no brain sign. Examine spine and cranium. There are no bony deformities. There are no bruit, gibbous, or tenderness. Cranium, no bony abnormality or bruit. Peripheral nerve examination. There is no thickening of peripheral nerve, no trophic ulcer. Carotid pulse are normal. There is no bruit. Cardiovascular system examination, JVP normal, apex normal plus, no palpable P2, heart sound normal, there is no thrill or murmurs. Respiratory system, chest symmetrically, no paradoxal movements, normal vestibular sound here, no abnormal added sound. Abdomen, soft, no orgomegaly, no ascites. Summary, 25-year-old female presented with a 3-day history of subacute onset, progressive dysarthria, dysphagia, pooling of saliva, associated with intermittent headache and diplopia, noted to worsen in the evening, following a history of intractable nausea, vomiting and hiccups. For 2 weeks, anastiness and diplopia improve at the time of examination, with bilateral decreased palatal movement, bilateral absent gag reflex, bilateral tongue weakness, left more than right, without any motor weakness, without sensory and cerebellar signs. Structure involve bilateral bulbar muscle innervated by 9th or 10th nerve, maybe at the nerve or maybe at the neuromuscular junction. Bilateral lingual muscle innervated by the 12th nerve, area posterior, cerebellum its connection improved. Our possible DD at the time of admission, brainstem demyelination, bulbar onset myasthenia gravis, and GBS variant. At the time of admission, we do investigation. Hemogram 11.2 gram per TL, TLC 9,400, platelet 1.6 lakh, ESR 10 mm at the end of 1 hour, C-reactive protein 5 milligram per liter, liver function test SGPT normal, serum blood urea and creatinine normal, serum electrolyte sodium 136 milligram per liter, potassium 3.8 milligram per liter, thyroid test TSH 2.3 milli international unit per liter, serology HIV DDR negative, COVID-19 RT-PCR negative, USG abdomen pelvis normal study. MRI of brain was reported as normal, taken before the admission outside. This is all MI at the time of admission. Second day of admission, dysphagia version, needing Ryle's tube for feeding, dysarthria version, BP and pulse rate were labile with shortness of breath, and decreased SpO2, transport for
of the four sections. I think the first two have many questions and the remaining
Hello, sir. Hello, sir.
You proceed.
Yeah, proceed.
At the second of admission, dysphagia worsen, needing relative feeding, dysarthria worsen, BP and pulse rate were labile with shortness of breath and decreased SpO2. We transferred to patient for ICU care. In ICU, she was afebrile, conscious, oriented time place person, patient tachypneic, requiring 6 to 8 liters of oxygen to maintaining SpO2 at 98%. BP fluctuated between 100 to 140 mm of Ag systolic and 70 to 100 mm diastolic. Pulse rate labile between 60 to 110 per minute. In ICU, gag reflex bilaterally absent, palatal movement absent, motor system examination in ICU, hypotonia in all limbs. There is pyramidal pattern of weakness, 4 minus by 5. All DTR just present, bilateral plantar extensor, sensory examination normal, cerebral examination normal. The brief summary, thus, 0 to 14 days, patient had interactive nausea, vomiting, hiccup, not responding to medical treatment. 15 to 18 days, difficulty in swallowing for both solid and liquid and pulling the saliva in oral cavity. Difficulty marshalling food with tongue. At the 19-20 day of illness, patient had dysphagia, dysarthria worsen. There is autonomic instability, pyramidal pattern of weakness in all limbs. The structure involved after examination bilateral bulbar muscle innervate 9th and 10th cranial, bilateral lingual muscle innervate 12th cranial, bilateral pyramidal tract area postrema, cerebellum and its connection. Possibility now here change, brainstem demyelination, GBS variant, and bulbar onset myasthenia gravis. We continue with injection methylprednisolone 1 gram tablet pyridoxine 60 milligram TDS. However, dysarthria and dysphagia worsen our next 2 days in ICU, and her BP and pulse rate is still fluctuating in ICU. We started injection IVIG 2 gram per kg. Total days over 5 days. She started to improve after 2 weeks of admission in ICU. These are MRI showing flare MRI showing hyperintense in dorsal medulla. Again, flare MRI showing hyperintense dorsal medulla. This is brain contrast. There is no contrast in enhancing lesion in dorsal medulla. This is T2 image showing hyperintensity around the fourth ventricle. T2 showing the hyperintensity bilateral occipital lobe. Repeat MRI brain contrast, T2 and flare, hyperintensity area postrema and occipital lobe. There is no restrict diffusion. Lesions are not contrast enhancing. Serum antibody to ecopyrin and MOG are not detected. Serum estrogen receptor antibody 0.04 nanomole per liter. Anti-MS was not detected. CSF examination acellular, protein 35 mg per dl, glucose 64 mg per dl. We did NCS, normal, sensory, SNAP and motor CMAP, conduction velocity and all are normal. FA are persistent, there is no coronal dispersion, normal minimal latency. We done RNS after discharge, there is no decremental or incremental pattern. VP is normal. These are test reports, serum ecopyrin not detected. These are blood immunology, estrogen cholesterol, anti-MS are not detected. And 2015, the International Panel of Opticus diagnosis announced with ecopyrin positive, at least one core clinical characteristic, positive list for ecopyrin IgG, taxonomic alternate diagnosis, neuromyelitis syndrome without ecopyrin for IgG, unknown ecopyrin. At least 2 or clinical characteristic at right, resulting for 1 or more clinical attacks and satisfying all of the following requirements. Patient should have at least 1 out of 3 optic neuritis, acute myelitis with LTM with area postrema. Patient should have dissemination spate more than 2 different core characteristics. MRI requirement applicable. Negative test for ecopyrin IgG testing unavailable. External alternate diagnosis. The following are considered core clinical characteristics: most common optic neuritis, acute myelitis, area postrema syndrome, acute brain syndrome, symptomatic narcolepsy or acute Hansen syndrome, a symptomatic cerebral syndrome with we diagnose this patient with area postrema syndrome and acute brainstem syndrome with T2 flare and T2 hyperintense in dorsal medulla, fulfilling the criteria of neuromyelitis syndrome 2015. Diagnosis neuromyelitis spectrum disorder. She was discharged on tablet 40 milligram per day and tablet azathioprine 50 milligram per day. These are research papers that supporting our diagnosis, area posthumous syndrome in your optic disorder, diagnosis challenge, and descriptive pattern. Thank you, sir.
Dr. Balaji,
Yes, sir.
you discuss clinically.
Sir, good evening, one and all. Once again, we thank the course directors for giving us the opportunity to learn and discuss this case. So before discussing the case, I just want to put forth the summary of this case in perspective so that you can just follow the happenings over a period. So the first 14 days, patient was treated outside for nausea, vomiting, and hiccups. She was rather evaluated in an extensive way, and the reason for nausea and vomiting could not be made out even after an extensive workup. But the nausea and vomiting has already subsided when she presented to us on the 3rd week of illness. In fact, she was seen by us on the 3rd week of illness. She presented to us with the dysphagia, dysarthria, and tongue weakness as described by Dr. Rajesh. And subsequently, after a couple of days stay in the wards, her presenting symptoms worsened. In addition to she added autonomic symptoms and a pyramidal weakness. And after treatment, she has recovered with a spastic weakness. So I would start from where we saw her first. It was around the 15 to 18 days in the neurology wards where she presented with the bulbar symptoms. The bulbar symptoms was associated with an absent gag. The presentation of unsteadiness and diplopia, which was present in the history, which didn't have an examination correlate, we thought it could be a soft sign in the background of such a long drawn vomiting. And the bulbar symptoms were localized to the element structures of 9, 10, and 12 cranial nerves. But in the background of nausea and vomiting and hiccups, which happened over a period of 2 weeks, wherein there is a clear-cut connotation of area post-trauma syndrome. On a background of area post-trauma syndrome, we localize these element cranial nerves to be at the nuclear level. So we thought it's an involvement of medullary brainstem, wherein the possibilities would be NMOSD, which is wherein area post-trauma syndrome is a prototype, as well as it could be a other demyelinating illness involving the brainstem. And in addition, we were not sure at the time of presentation whether this vomiting could be a non-neurological one. Though she was evaluated fully, this could be because of a non-neurological cause, wherein the element 9, 10, and 12 cranial nerves could be a part of a site-restricted, could be because of a site-restricted GB syndrome was also an alternative thought process at the presentation. Also, the patient as well as her attenders, they were telling about a diurnal variation of symptoms. So we wondered whether it could be a myasthenic syndrome, which is rather a bulbar presentation is a characteristic feature of a MuSK antibody, dissociating this nausea and vomiting and hiccups to be a non-neurological cause. So the other causes of extrapontine demyelination was not considered because the patients already come with an MRI which was negative. MRI was normal at the time of presentation. So while she was on treatment, subsequently she worsened her symptoms of dysphagia and dysarthria, and there was a very disturbing autonomic symptoms. The patient could not even move from her bed. She had a fluctuating blood pressure and pulse rate. And she also had a weakness, a new onset pyramidal weakness just happening in front of us. So now the localization was rather easier for us with the involvement of bipyramidal tracts and the highest level of the cranial nerves being the medulla. We localized it to the adjacent structures of hypoglossal nucleus, the motor nucleus of vagus, as well as the nucleus tractus solitarius for autonomic involvement, and the pyramidal tracts at the level of medulla. So putting things into perspective, the first 14 days, the first dot was the area post-trauma syndrome. Then the subsequent happenings after admission, the bulbar symptoms, worsening of bulbar symptoms, addition of autonomic and pyramidal. Again, it gives us a new brainstem syndrome after the area post-trauma syndrome. And our extensive evaluation, whatever we could do, the NMO IgG was negative, MOG was negative. The previous MRI with which she presented was also normal, but the MRI which we took subsequently after 2 weeks of admission, we could get an MRI only after 2 weeks of admission, which showed clear-cut flare hyperintensities at the dorsal medulla, the floor of fourth ventricle. So the interesting part in this case is that we just had this area post-trauma syndrome, a brainstem syndrome, but how to make a diagnosis of a neuromyelitis optica, though it was staring at us, the area post-trauma syndrome is a very prototype of a NMO-SD spectrum. But with the absence of NMO-IgG, how we proceeded is what we want to share. This is the 2015 International Consensus Diagnostic Criteria of NMO spectrum disorders. The first part, when the aquaporin 4 antibodies are positive, the life is very simple. You just need one core clinical characters, a positive aquaporin 4, and exclude other alternative diagnoses. You make a diagnosis of NMOSD. But in our case, where the aquaporin 4 was negative, the aquaporin 4 again is not a cell-based assay which we did. But here I need to mention that if you do some other assays, as in an ELISA or the other assays, you have more of a false positives. So our case was NMOSD, the aquaporin 4 negative, wherein we needed at least 2 core clinical characteristics, whether it can be because of one attack or it can be because of multiple attacks. At least one core clinical character must be an optic neuritis, acute myelitis with LETM or area post-trauma syndrome. We were convinced it's an area post-trauma syndrome at the first instance. Then for the second, we need a dissemination in space, wherein we need 2 or more clinical characters and a fulfillment of MRI requirements, which you'll see in the subsequent slide, and the negative aquaporin 4 and exclusion of alternative diagnosis. So the lower part of the slide shows the core clinical characters: the optic neuritis, acute transverse myelitis, area post-trauma syndrome, acute brainstem syndrome, a symptomatic narcolepsy, and a symptomatic cerebral syndrome. So the B criterion, the dissemination in space, was satisfied by the 2 core clinical characters of area post-trauma syndrome and a brainstem syndrome. And the MRI character, the patient also had a fulfillment of MRI requirement, wherein she had a hyperintensities of the area post-trauma or the dorsal medulla. So since this case started from the a symptom which is a area post-trauma syndrome, we just want to go through the literature on how this area post-trauma syndrome and NMO spectrum disorders are linked. In fact, from the late 18th century, we have literatures on the area post-trauma syndrome. It were post-mortem studies on a tubercle of medulla oblongata. Later, a brainstem tumor, which started as a hyperemesis, which started as an area post-trauma syndrome. Then it went on to involve the entire brainstem. Also, an epidemic hiccup, which happened with encephalitis lethargica. And the irony is that area post-trauma syndrome until 2002 was thought to be a part of multiple sclerosis. There are several seminal papers where area post-trauma syndrome was linked to multiple sclerosis, probably before the NMO spectrum disorders came into vogue. But it was this seminal paper which happened in 2005 in neurology, wherein they looked at a group of patients with intractable hiccups and nausea as an index event. They found 8 out of 47 patients have had a relapsing NMO spectrum disorder, compared to none in 130 cases of multiple sclerosis. So then came the 2015 criteria, wherein the area post-trauma syndrome was included as a very core criteria for diagnosis of NMO spectrum disorders. So the area postroma syndrome is a pearl in the demyelinating diseases. It's now considered both with a diagnostic as well as a prognostic significance. The diagnostic significance we have seen, but the prognostic significance is that the severity soars with the presence of the area postroma syndrome. Relapse rates are more. The longitudinal extensive transverse myelitis occur more frequently when you have an onset with an area postroma syndrome. And there are now papers coming up where MOG IgG is positive and aquaporin 4 negative in this area postroma syndrome group of patients. And a small literature review on the area postroma syndrome. Our patient had a duration of about 2 to 3 weeks before she presented to us, before she went to pillar and post for the vomiting, nausea, and hiccups. The general mean duration of symptoms of area postroma syndrome. Of course, these are patients who had aquaporin 4 positive NMO-SD disorders. The mean duration was about 10 to 14 days. The nausea and vomiting can be continuous or it can be episodic. If it is episodic, the general duration range is about 5 to 10 days, and it can even awaken from sleep, which is a significant symptom associated with this area postroma syndromes. And the frequency of an isolated area postroma syndrome at NMO spectrum disorder onset was 7.5 in UK and 8.7 in Japanese and 10.3 in US patients in various studies which we reviewed. And one another symptom in our patient is the autonomic dysfunction, which we had in our patient, which happened in front of our eyes, which in fact debilitated the patient more than the weakness part. Going into literature, there are very sparse systemic studies looking at the severity, frequency of autonomic symptoms and spectrum of autonomic dysfunction. Even though there is a predilection of critical areas of autonomic nervous system pathways in these disorders, they can have an hypothalamic involvement, they can have a brainstem involvement and a center of spinal cord involvement, which are areas where the autonomic nervous system traverses, but there are very sparse papers. But fortunately, I found a dissertation, a thesis paper, which was submitted to our own university in 2014, wherein a resident has looked into the autonomic dysfunction in neuromyelitis optica and NMO spectrum disorders. It's a very prospective study involving a small group of 20 to 25 patients. There he has found that the prevalence of autonomic symptoms are very high in this NMO and NMO-SD disorders. The abnormalities are found in up to 80% of patients during remission and 95% during active phase. Almost every patient have had an autonomic dysfunction, which is less reported. The parasympathetic cardiovascular rates are common than the sympathetic cardiovascular function abnormalities. There is correlation between the EDSS score at active phase with MRI changes due to involvement of specific areas of brain and spinal cord. In fact, one of the reasons to bring out this case is the autonomic involvement in the patient with the NMO-SD disorders. A final word on aquaporin 4 testing. It is best tested in blood as CSF testing is less sensitive. The cell-based assays are now recommended. They have a sensitivity of 75% to 80%, a specificity nearing 100%. Our patient was done with an ELISA technique, which is available here. The ELISA technique is less sensitive and has a 5-fold risk of false positives. Thank you.
Thank you, Balaji sir.
Thank you, sir.
Thank you, sir. It's a young female with intractable vomiting followed by progressive bulbar dysfunction worsened in 3 days. And also, patient worsened within 3 days, attender confused with the evening worsening of symptoms, the MR normal, aquaporin negative, all made us confused. But the modified criteria gives us a clue. So the simple modification of the criteria make it aquaporin positive, negative, and unknown status, all with the typical core clinical features to fall under one NMO spectrum criteria, NMO spectrum disorders. And that is the beauty of the modification. And interestingly, this case well responded with the IV immunoglobulin. A single attack of another attack of NMO spectrum disorder may leave a patient blind or paraplegic, or may result in death due to respiratory involvement. So effective preventive therapy is of utmost importance, and the therapy initiation should be started as early as possible. Literature says steroid non-responders well responded with IV immunoglobulin or plasma exchange. Here also patient well responded with IV immunoglobulin, not responded with methylprednisolone. So the NMO spectrum disorder causes significant morbidities and at times mortality. So prompt and accurate diagnosis followed by swift initiation of therapy for acute exacerbation and the prevention of further relapse is critical. So that's why we presented, sir. Thank you, sir. Course Director Dr. Lakshmi Narasimhan, sir. We thank for your guide and give us the opportunity to present. Thank you, sir.
Thank you. Thank you for a wonderful presentation. And as all of you know, that after the advent of the NMO spectrum group of disorders, which spans into and can masquerade into any of the types like the diencephalic syndrome or the ariopostrema syndrome or the optic neuritis or the myelitis or a combination. And not only that, the combination with systemic symptoms of various autoimmune diseases. So this has opened up a new arena, and one should understand that the differences between the humoral immunity attacks and the cellular immunity attacks, and how much of humoral components and how much of cellular component in this. So, and the treatment is also entirely different among the central demyelinating disorders. The approach to NMO is entirely different than the approach to the multiple sclerosis. Not only that, now the newer entities like MOG has come, and which have a different propensity for different areas in the brain. So in totality, this is a very good case. Thank you for highlighting a beautiful, and Balaji, I really enjoyed your analysis of the literature, and I'm also very happy to know that the dissertation by the student, and I think that needs to be published because it has given lot of newer insights and ensure that it gets published. And my hearty thanks to Dr. Ilangovan, my hearty thanks to Dr. Balaji, and my hearty thanks to the Rajasthan hero of the day, the person from Rakesh from Rajasthan, from the SMS Medical College, where he comes from. And my sincere thanks to all of you. And I'm very happy that Chengalpattu Medical College is doing a lot of good academic work, and we are proud of you. And I thank my co-course director, Professor Sudhir Shah, is a visionary. He said that this neurological secrets will have 4 sections. The first section would be the localizing one, and the second section would discuss another person would discuss on the etiology and the differentials, and the third section would essentially on investigations, like which includes the neurological, and either it could be blood based or investigations like nerve conductions and other things, or pathology. And the fourth one is the approach, the final conclusion remarks by the HOD on the take home messages and the therapeutics. So this pattern of 4 sections was suggested by him, and that is what makes this very interesting, because in 1 hour you try to learn a lot of good things and a lot of take home points. And I thank Professor Sudhir Shah for being the visionary in the designing of this. My sincere thanks to Heli, Arun Chanda, and the entire INTAS group of people. My sincere to senior faculty, my thanks to my teacher, Professor Banu is there. I saw her in the attendance. Madam Banu, Madam Banu, you have any comments, madam? I saw her if you could get her in the online, we'll be very happy.
Yeah, should I get her in the panel?
Yeah.
So she is in the panel.
Madam?
Hello.
Madam, your comments, madam.
Yeah, see, I wrote a very good presentation. I have a question. Many times I see patients with intractable nausea, vomiting, and hiccup. Okay, and suppose aquaporin 4 turns positive. What do you do at that time? No neurological manifestation, just a gastrointestinal. Do you use any therapy at that time to prevent the neurological manifestation? Hello?
Balaji. Dr. Balaji, madam is asking you, when it comes to
Madam, good evening, madam. I don't know whether it's a relevant answer, but we just looked into literature where patients with NMO spectrum disorders, they were retrospectively questioned for this.
Yeah, that I agree. Balaji, that I agree. Once they develop the NMO,
Yes,
many
madam.
of them had intractable vomiting. My question is, when you
just have-
see them before the NMO, the neurological manifestations develop, and you evaluate with an aquaporin 4 antibody test and turns positive, do we do anything so that the patient does not develop neurological manifestations?
I have two
Because there's some
answers.
literature which says they present only with this, and
Yeah.
at that time you should use immune therapy to prevent neurological manifestation because many of them lose their vision. But the full literature is not available to me. That's why I asked this question.
Yes, madam. The first part, madam, when we look into literature of the people with
Hello?
NMO disorders who are questioned, the mean
can't hear
age
you,
between a development of a area, I mean, intractable vomiting and development of other
Who?
symptoms are even months.
You are.
One. Number
One
two,
second, I can't hear you. I can't hear you. Hello?
if a patient has an intractable vomiting and an NMO spectrum disorder, a NMO antibody positive,
yes,
Hello?
hello?
Yes, now I can hear you, Balaji.
Yes, madam. Yes, madam. When NMOSD patients were asked a questionnaire on the occurrence of this intractable vomiting and development of the new clinical symptoms, some patients have said even months have elapsed between pure vomiting and the development of neurological symptom. But again, your question is a very gray area wherein if we apply this strictly to the criterion, NMO spectrum, aquaporin 4 is positive, then you need one core criterion to tell it is an NMOSD patient. For that one core criterion, you need an area post-trauma syndrome or a myelitis or a
That is, by
but
then the neurological manifestations are there.
I think it's a very gray area to look into, madam. I think we need to find such patients and really look into their.
like, see, the madam's question is
Yeah.
like clinically isolated syndrome or even radiologically isolated syndrome, like where do you give anything for prophylaxis is what madam is asking.
Yeah, because many of them lose their vision, no, if they develop optic neuritis.
Madam,
Yes, yes, Ilangovan.
sir, according to the modified criteria, they should have two core clinical symptoms. If aquaporin 4 antibody status not known or negative, if it is positive, no problem. You asking question positive with area
Sir,
posthuma syndrome.
No. Patient has just intractable vomiting. You do a test, you're getting aquaporin 4 positive. No other neurological signs or symptoms, clinical or radiological.
Yes, madam. If there is radiologically, it is fulfilled and you exclude the
Yeah,
alternative diagnosis, you can start. According to the criteria, when say one core clinical characteristic is enough with the positive antibody, you can start. Here, this patient aquaporin antibody negative initially.
I know, I'm not talking about your patient. Whatever you
Okay,
said,
madam.
I agree. I am
Yes, madam.
asking, see, because recently I saw two patients who presented with just intractable vomiting and nothing else. The full gastrointestinal investigations turned
Okay,
out to be
madam.
negative.
Your question answer is in the criteria. Sir, Balaji sir, you put the criteria table.
What criteria?
Madam, The
Sir,
answer
Lakshmi, tell me.
is invariably
Ah.
now even an isolated area post-tumor syndrome where vomiting is the only symptom, if
Ah,
seropositive, you start
Ah.
immunosuppression straight away.
Yes.
okay, okay, that's it. That's what I wanted. Okay.
If it is seronegative, you
Ah.
keep monitoring, you can see, you can keep monitoring the patient. But positivity,
Ah,
at least even if it's one core criteria like
You can start.
Seriopostumum, the core criteria, madam. At least one of the.
okay.
You can start.
So if it is positive and seropositive, one core criteria, start the immunosuppression.
You can start the treatment.
Okay.
Immunosuppressive treatment.
Okay, okay.
And the key word is exclusion of alternative diagnosis. madam.
Diagnosis, yes.
Third
yes.
is the exclusion of alternative diagnosis. Because
Yes.
you have aquaporin 4, you have one core clinical positive, then the important on the if we can confidently exclude alternative
And
diagnosis.
also MRI, if there is area prostima in the MRI,
Yeah, then there's
Then
no
no question.
issue.
no
Ah,
question.
This is where it is negative only my question came.
Yes.
Yes, madam.
And it's
Okay.
more relevant in a
For the
patient
sake of
with hyperemesis gravidorum, madam. This is more relevant in a patient with a hyperemesis gravidorum.
Okay. Ah,
Madam, one more
Okay.
thing. There
Ah.
are many reports where the first test of aquaporin would be negative. There are
Follow-up will be positive.
the invariably 6th or 7th time when you test, it has become positive. There is one Japanese paper where it has become positive only on the 10th attempt. So the first time aquaporin negative, it does not mean you have ruled out neuromyelitis optica. You keep repeating. If the patient becomes symptomatic again, you always keep repeating the test until you get the answer. So this is another important message which I wanted to. Thank you.
I'll just add on one thing to it, Lakshmi, if there is time. I had a patient for whom aquaporin was negative and she had multiple bans on oligoclonal testing. She was on treatment for multiple sclerosis, doing quite well with rituximab, developed one episode of saying relapse. And then aquaporin became positive. Hello?
OC positive is a red flag, madam.
Yeah, the OCB positive was there. Multiple bands were positive. And finally, there's a third or the fourth aquaporin became positive now. She also, she also did very well with natuliximab. Now she's on rituximab. She improved well with natuliximab. And she was on it for more than 18 months. Before that, tried other drugs also. This I'm telling, she became positive. I don't know whether Venkat is there in the panel. Is there in the audience. She was negative for about 8 to 9 years, and then the aquaporin became positive now. So,
In fact, one of the longest patient who had a quadriparesis with the cervical 1983. At the time, there was no aquaporin. Recently came with some exacerbation. I did it just become positive. It's almost 20 to 30 years. I didn't know whether the initial episode was NMO or not, but now he's strongly positive. And he got the label of NMO after 25, 30 years.
Okay.
He's wheelchair bound 30 years. I got 2 patients who are wheelchair bound 30 years, old timers, had paraplegia, residual paraparesis, and both of them turned out to be positive. And thank you so much, madam. Thank you for your.
Right. Okay. I've just got one this thing reference. I'll just tell you what it is. Just to answer. I was looking at it. That's why I came. Intractable nausea and vomiting from autoantibodies against brain water channel, and they said the conclusion was though spectrum NMOSD is rare, tests for aquaporin 4 IgG should be considered. Patients often explained vomiting. Okay. Detection of the antibody before the development of optic neuritis or transverse myelitis allow patients to receive immunosuppressive therapy before the development of neurological disabilities.
Yes,
this is what I was looking for, and I got it after you spoke to me.
This is what I was telling.
This is in 2012. Actually, when I looked that day, I couldn't get an answer. 2013. This is in Clinical Gastroenterological Hepatology Journal.
Thank you, madam. Thank you.
Thank you. Thank you. Thank you.
Thank you. And sir, Professor Sudisha, sir. Sir, you can wind up, sir.
Sir, one more
May I suggest
question.
you to do that?
Sir?
I suggest you to do that because I'm busy with something else. Can you please do that?
Okay, sir, I'll do that. Thank you. I take your permission, sir. I close that.
Thank you. Thank you very
Is there any
Presentation.
when
Very
Heli,
good
you are telling something?
presentation, good discussion.
Sir,
Thank you
one
very-
question was mentioned in the Q&A box.
Yeah, I'll just see that. I'll answer that. Kampa, this is a question from an anonymous attendee. Can IVIG and methylprednisolone be given at the same time on the same day?
So with respect to this particular patient, sir, he presented with a bulbar symptom
No,
after
not with the, it's a general question, not with reference to your patient. Can they be combined? What
Let
is
us
your
start
opinion,
with the-
Balaji?
No, sir. The
No, sir. We start
the-
IVIG, then go for steroid.
either, sir. Combination of both, I don't know. I'm not sure, sir.
But in fact, there are overlapping, there are studies with overlap of steroids and IVIG. There are enough studies are there, but only thing, the only risk is you understand that IVIG is a very high molecular weight substance and it can always, your renal status has to be, you have to be very careful with the renal status. And there are anecdotal reports I have seen where they have started on the 3rd or 4th day when they don't see any improvement, they have started on an IVIG, or sometimes what happens is during the middle of the IVIG, they would have got the report of some reports have come where they have to, they don't want to waste the time and then start for the last 2 overlapping doses. Those sort of things have always happened. There are a lot of anecdotal reports, nothing on, but we should be careful. But as a treatment of choice, it should be either one. But when our situations arises where you get a result at the 3rd day or 4th day where your patient is on methylpred, there's nothing wrong in starting the IVIG where it is, if it is indicated. That's what that is what my opinion. Okay. Anything else, Heli?
So just one small comment where in the chat box where Dr. Renu Misra has mentioned that the gastro physicians should also be informed about this intractable singultus and vomiting area prostrema syndrome, so that they
Yeah,
don't
in
miss
fact,
NMOSD.
Yeah, in fact, the time they take is quite long. I completely understand that we should start having our liaison things with gastroenterologists, because many a times they keep working on lot of motility studies, all those things on looking at the gastrointestinal motility and a lot of other things which they keep looking at. And I think the increasing the awareness for them on this aquaporin channel is a very, very important job of the neurologist. I agree with you. Thank you. Is there anything else, Sally?
So 3 more questions have just come up in the Q&A box.
Yeah.
You want me to read, sir?
Yeah, 1 minute. A little top of a patient with intractable vomiting, we should always get MRI and CSF. Yes. That's what I feel. What is your opinion, Balaji?
Sir, I didn't get it, sir.
Well, intractable vomiting, we should always get MRI and CSF.
Yes, obviously after a gastro workup, I think we
Yes.
should get a
And second
MRI.
question is, does sending NMO serology after starting steroids reduce the yield of positivity, or if yes, how much?
No, sir.
Does it affect? I don't think so.
I don't think so, sir. Yes, sir. And
Okay.
one point which I want to add here is, sir, the presence of NMO positivity after 6 months predicts an impending relapse. The incidence of relapse is more when the NMO serology status still remains positive after 6 months.
Okay. What is the dose of rituximab Madam mentioned, and how often do you give rituximab with MS?
MS.
Sir, we can start either, sir, 375 milligram per meter square or 1000 milligram once or twice a week at least 6 months, sir.
For MS.
Monitoring the CD, monitoring the CD
20.
20.
At least 6 months, sir.
Okay, thank you. Any other question, Heli?
One from Dr. Partha Ray. Did the first MRI upon review reveal abnormalities?
No.
Sometimes what happens is the area postrema is a very tiny area around the in the floor of the fourth ventricle. So I think many a times neurologist who is looking for that would get the lesion. The radiologists are likely to. I have seen at least few times here where things are reported normal, where you go and take that image and then zoom it, and then you'll see what you're looking for in the medulla section. Because even in the MRI, unless you have a real unless you really look for it, you're likely to miss it. Okay.
Wonderful and enjoyable session, Lakshmi.
Thank
Thank
you.
you.
Thank you.
Thank you. Thank you.
Thank you so much.
Thank you,
Thank
Balaji,
to
also.
all the participants. I thank every one of you, Dr. Ilangovan, Dr. Rakesh, Dr. Balaji, and Professor Sudhir Shah, Haley, Chadda. I thank every one of you. We'll be meeting on the next episode on the 25th of March, and I'll finalize the venue and let you know, Dr. Haley, because on 25th of March on Friday 8 o'clock we'll be meeting. Over to you.
Yeah, thank you, sir. Thank you so much. And this was indeed a very enlightening session, and I'm sure all the delegates present here would have learned a great deal. On behalf of Intas Pharmaceuticals, I would like to thank the faculty of Chengalpat Medical College, Dr. Rajesh Kumar sir, Dr. Balaji sir, and Dr. Ilangovan sir for the wonderful case presentation. I'm also grateful to Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir for their expert guidance and comments for the case. A wonderful discussion happened today. With this, I sign off for today with a promise to meet you again next month and have such wonderful case presentations and interactions. Thank you so much. Thank you, everyone. Thank you for joining us, and have a good night. Stay safe.